For most people at the community level, screening scale is fine. But just thinking about, okay, so if it's screen's positive, what do you do? So we talked about that the last thing. And again, part of it is just knowing what kind of things are available in your community. You can actually really be very effective, even with pretty limited resources, if you are aware of what other services are in your community. No matter where you are in this process, you can still do things that will actually help. So many women just fall through the cracks. And so every time a mother has any kind of interaction with any healthcare provider at any level, and even volunteers, I would include you in there, you can actually make a big difference by doing the first step that gets them heading toward treatment. Morning. I'm Dr. Kathleen Kendall-Tackett, and this is the Science Chick Report. And today we're going to talk about two of the most common measurement tools that are used for postpartum depression. I just kind of want to talk about some practicalities here. This is actually kind of an interesting question, because it's like, which tool should you use? Well, it sounds kind of academic, but there's some real world consequences to it. And I think it's important to acknowledge those and understand that there are some pros and cons. And so there's some things to think about as you decide which one of these is better. Now, some studies actually decide to use two of the major tools, or they may use more than one kind of standard diagnostic tool as well. But let's talk about just generally what these are. Okay, so we're going to talk about the Edinburgh Postnatal Depression Scale, and we're going to talk about the Patient Health Questionnaire. And you might think, oh gosh, this is so boring. What does it matter? Well, it does actually matter because it really kind of can frame what you're going to do next. And that's something I want kind of to reemphasize from the last time, is really it's important to not just use a screening scale, but to really have a pretty good idea of what you're going to do with it, because it really does matter. It matters what you're going to do with it. What are your goals? What are you trying to do? So many times I've been places and people have said, oh yeah, we've got this, thing in place we're doing for postpartum depression. And I say, oh, that's great. What are you doing? And they'll say, well, among all their other paperwork, we asked them to complete an Edinburgh Postnatal Depression Scale. And I just kind of go, okay, and then what? And I said, who scores it? Well, we don't really score them. And I said, okay, do you do anything with the results? Well, no. So it's like, at that point, there really is actually honestly no point. So really, I mentioned it the last time, I would encourage you strongly, please be thinking about what you're going to do next. Because yeah, there are some steps you can take, and even if it's just referrals, but it's kind of not really fair to measure something and then not do anything with it. It's actually not fair to the mothers, because it creates an expectation in them that something's going to happen that's going to change things, and then nothing does. And then they think, well, what's the point of that? So it is something important to think about. The other thing is you want to kind of think about what this actually is. So these two scales that I mentioned, they're the most common ones in use. What they are is screening scales. And, you try to say that to people, and, you look at the literature, and everybody's using those two scales like diagnostic tools. Okay, so if you're going to give somebody a formal diagnosis of postpartum depression or anxiety, you need something that is the next level. The screening scale says, okay, there's something here, let's look further. So again, it's kind of important to kind of keep in mind, for many people's purpose, the screening scale really is enough. But the screening scale should be the first of the next series where, like let's say you refer somebody to get a proper assessment, they'll then get a diagnostic scale. Okay, so, but for most people kind of at the community level, screening scale is fine. But just thinking about, okay, so if it screens positive, what do you do? Okay, so we kind of talked about the last thing. And again, part of it is just knowing what kind of things are available in your community. You can actually really be very effective, even with pretty limited resources, if you are aware of what other services are in your community. That's the thing, no matter where you are in this process and seeing new mothers and stuff, you can still do things that will actually help. And it's like, so many women just fall through the cracks. And so it's like every time a mother has any kind of interaction with any healthcare provider at any level, and even volunteers, I would include you in there, you can actually make a big difference by doing the first step that gets them toward heading toward treatment. So let's talk about the first one, the Edinburgh Postnatal Depression Scale. Now, this one's been around for a long time. When I first started working on the very first book back in 1990s when I got the contract, so I was writing the book in 91, 92. It came out in early 93. The Edinburgh was really pretty much what was it. That was what everybody was using. And a lot of people here weirdly call it the Edinburgh. Now, the reason I say that's weird is because it's from a city in Scotland called Edinburgh. So nobody up there ever calls it Edinburgh. So yeah, it's kind of something that makes me cringe when I hear people say that. It's kind of like, you can't change the name of the city, folks. But it was basically meant to be a tool that could be used in primary care settings in Scotland. And yet because it was available and because it was free, people started using it all over the world. It's been translated dozens of times. But there are some difficulties with it. Okay, so, that's the thing. It probably has the longest track record of validation. The first publication of the scale was in 1983. So again, been around a long time. Now, it's got, there's been, people have pointed out some issues with the scale, and I also have some concerns about it. It's fine, but I think there's actually honestly better choices. But, if it's one of these things, let's say you're doing a little study and you want to compare it to results from other studies, the Edinburgh can be helpful. Now, the advantage that a lot of people like with it is, it's a 10-item scale. It can be administered very quickly. Seems to be pretty easy to use, but there's a couple of disadvantages. One is a couple of the items are reverse scored, which means that a low score is serious. For most of the items, it's pretty straightforward just conceptually to think a high score means more symptoms. But at least two of the items are reverse scored. And so there have been actually studies that have said a lot of people have taken these and scored them and got the score wrong because they didn't account for the reverse scoring. So, if that part gets a little tricky. So that's one kind of thing that's a problem. The other thing is, and I think this is honestly the biggest limitation, is the language. Because, Scotland, of course, it's written for mothers in the UK. And so it is kind of colloquial. So for mothers in the UK, it's very accessible because of that. But there's expressions in the UK that you don't necessarily hear in other parts of the world. Things are getting on top of me, which is, trying to assess whether you're overwhelmed. And so as you can imagine, there was one very nice lit review where they looked at this used in low to middle income countries. And they said, trying to translate it word for word just didn't make any sense. That you almost had to translate it conceptually, that was better and yielded better results. So that's one thing. And, again, a lot of American mothers, for example, will sit there and say, what? I don't know what that means. So they may not check an item, even though they do feel very overwhelmed. I've also found, interestingly, the sleep item to be actually not a very good predictor. There's an item on there that says something like, I've been so depressed, I've had trouble sleeping. And so you would think, others would check that. But what seems to be the issue is they're not connecting their depression to their lack of ability to sleep. And so that's been kind of interesting because it's like, okay, they say that they're depressed and they're having trouble sleeping. But what does that mean? So anyway, it's just tricky. And where I said I think this been a problem is we did a big sleep study and we had 6,410 moms and I included the Edinburgh. Anyway, what ended up happening, which I thought was interesting, was these mothers were reporting rampant sleep problems, huge sleep problems. Less time getting to sleep, less time in deep sleep, more daytime fatigue, all these sleep problems. And yet we're basically checking no on that item. So that item wasn't measuring something that was actually really there. So, again, there's just a couple of things. The other thing is that there are different versions of the Edinburgh. And one of the ones that seems to actually, believe it or not, have better validity and reliability is the 3-item version. So it only looks at 3 items, and it actually seems to pick up on more than the full 10 item. it's like the other items seem to dilute the content. So if you're going to use it, sometimes I would probably steer toward the 3 item. And so you can actually get that online as well. So just type in EPDS 3 and it'll come up with a version of it for you that you can use. That's the nice thing. All these scales are available online for free. Okay, so there's been a lot of validation with it. Now remember, it was originally designed to talk to postpartum mothers in one specific city. But, again, as it's been used so widely, pretty soon they have versions that have been used for pregnant women. Wasn't designed for that. It doesn't stop people from using it, but, even the writers of the scale said, hey, it wasn't designed for that. It's been used for dads. It's been used past the postpartum period. So there's just been a lot of kind of application of it that's broader. In some ways, it's good because you can actually see it seems to work in this situation, but it really wasn't designed for that. But it's been validated against, a diagnostic tool, which is the Center for Epidemiologic Studies Depression Scale, or the CESD. Also, it's been validated against another diagnostic tool. So again, that's a more in-depth questionnaire that really is set toward making diagnosis of depression. And that is actually the Hamilton Depression Scale, or what's called the HAM-D. So those are both very widely used diagnostic tools for depression. And we can actually compare the results of the Edinburgh against that. And so it's like if it comes up with depression on both scales, you could say you have validated against this more established scale. This tends to be how they do it. Now, again, the challenge of this is what a lot of people have raised over the years is, are you measuring depression or are you measuring something else? And I would say at this point, we have enough of a track record with both those tools to say, no, we're measuring depression. Because we have a list of symptoms. If the mothers are exhibiting these symptoms, plus it's showing depression on both scales. So that's just kind of the nuts and bolts about how you validate. Now, what's interesting is the Edinburgh, if you use the full scale, they have a couple of different cutoffs that you can use for mild depression versus severe. And there's been some interesting discussion in the literature. And at first, I didn't find this very interesting because I thought, well, this just seems like kind of a methodological quibble. And why would we be interested in that? But it was kind of like, are you going to use the lower cutoff? Or are you going to use the higher one? So the higher the score, obviously, the more severe the symptoms. And so higher cutoff score, so usually anywhere from 12 to 14, if they score on that, then that's considered more severe symptoms. But if you go from 9 to 11, it's a broader net. And so you actually include more people, but you also include people with milder symptoms. And so you think, okay, well, what's the real world consequence of this? Well, the real world consequence is, do you want to do a broad net and catch everybody with symptoms? Or do you just want to really focus it on the mothers with more severe symptoms? And so that would kind of give you an idea of which scale you want to use. Now, for me, a lot of times I'd be wanting to say, let's get everybody, because oftentimes symptoms that start out mild become more severe. And, of course, you really want to kind of address that before it gets severe. But some people have raised kind of a serious and concerning practicality, which is sometimes you don't have the resources to deal with everybody. And so you really need to just focus in on the mothers that are most at risk. That actually is a valid point. I think it's kind of a heartbreaking choice. But one recent study, it was just published in 2023, was saying, they didn't do screening for depression because they were worried about overwhelming their already overburdened healthcare system. Wow, that's very unfortunate. I understand there's realities there, but that just, to me, that's not a choice I would want to have to make. So again, if that is the case, then that makes all the more case for why it might be good to transfer some of this into talking about what you can do at the community level if mothers do screen positive. Not necessarily go through the medical system, but could you go through the mental health system? Could you go through other types of support and stuff and working with mothers more directly? And yeah, the answer is yes. So high score versus low, again, it's something to really think about, and it's something to be realistic about. If you've only got the resources to treat a few women, you probably want to go with the higher cutoff. But lower cutoff is if you want to get everybody. So when we talked about the Edinburgh 3, it focuses on 3 items. It's just 3, 4, and 5. And these are items a lot of times that tend to be associated with anxiety symptoms. So I have blamed myself unnecessarily when things went wrong. I've been anxious or worried for no good reason. I felt scared and panicky for no good reason. And again, there are people who definitely take it, offense at this language, are concerned about this language is for no good reason because they feel it's kind of judgy. But again, I think written in kind of that colloquial British English style, I don't think mothers in that context necessarily interpret it that way. But that is something that has been raised. Now, there is also 2-item Edinburgh, but that actually hasn't held up very well. Reliability and validity of testing all 3 versions against each other. The full Edinburgh, the 3-item, the 2-item, the Edinburgh 2 I wouldn't use because it just doesn't score very well. And I have looked forward with enjoyment to things. So if you say no to that, that would be considered anhedonia, which is the inability to experience pleasure. It's a pretty significant symptom of depression. It's a worrisome symptom too, because oftentimes that increases the risk for suicide. So obviously important, but somehow it's just kind of not doing a good job measuring. And I have felt sad and miserable. So what they're trying to do is actually kind of match one of the other scales I'm going to talk about, which is the Patient Health Questionnaire 2. Okay, but this one does not have great reliability. But the Edinburgh 3 actually does. And when I made a little kind of cheat sheet that was laminated that health visitors could put in their bag as they go out to see moms, I did include actually the Edinburgh 3, just because, again, you have to do a quick scale. Then that's a good one to be able to use. Okay, because it gives you an idea. What you're looking at, this is information. And then it's kind of like, okay, this is positive. Anything with Edinburgh 3 is 4 above, like 3 or 4, you want to be looking at in more detail. And sometimes what you do in that case is maybe give a longer version and see if we can kind of pin down what's going on. Now, what has been kind of interesting is there's developed actually right before I finished the new edition of the book, so it came out in 2023, was a Edinburgh Postnatal Depression Scale US version. And what they did is tried to make the language less colloquial British, which I think a lot of people have liked. And they also just changed some of those, like they got rid of that for no good reason. So that one is actually still in testing. Honestly, I would probably just kind of maybe wait and see. But, if you could look it up, the author of that is Moyer et al., and that's 2023. That might be something to take a look at. You could actually just type in Edinburgh Postnatal Depression Scale US, and it'll come up on PubMed. PubMed's available online for free. Just Google it. You'll come up with the link. Okay, so a couple of the versions have been the version for partners, and there's also been a lifetime version. So again, like I said, kind of getting way beyond the original scope. But, it gives you the idea that this has been a measure that a lot of people have liked over the years. Dozens and dozens of studies, but some noting also some issues. Part of it is, just this kind of we're going to do some takeaways. This is a couple that I wrote down. Many programs administer the EPDS because it is so widely used. But it's kind of like there used to be an old expression in business, which was, you won't get fired for buying Hewlett-Packard, which kind of meant that Hewlett-Packard was the established office equipment, and you won't get fired for that because it always works. Versus if you buy some knockoff, you might get in trouble. So that, I think, has driven kind of a lot of it. It's kind of like, well, this is the one we know. And so, it is widely used on that. But really consider also, too, if it's appropriate for your mothers, because especially in some contexts, this colloquial British English really is confusing. Some others just kind of roll with it, especially if you explain what it means. But, again, like I said, really kind of think about it. Your mother's better than anybody. But also, too, that the scoring mistakes is something that is concerned, especially if you're really pressed for time, and you're not sure who's going to be able to take the time to score this. You want to make sure that it's scored correctly. Otherwise, why do it? But also, too, again, thinking about, are you going to do more of a broad brush, are you going to really just focus in on the mothers at highest risk? So you're going to go to the 9 to 11 cutoff, or that 12 to 14. But there are people that have actually noted that the U.S. version seems to show some promise. I don't think the numbers are there quite yet, but there's really no harm in giving it a try. And they really felt that because it's not in a colloquial language, that it actually may translate more easily into other languages. Okay, so that is the Edinburgh. Okay, so let's talk about the other one. And these are ones, honestly, that I lean a little more toward. Although sometimes, like when I've done studies, I'll include both. And sometimes that there's some kind of interesting comparisons you could do. Okay, so the other is a group questionnaires, and I say group because there's different versions of them, called the Patient Health Questionnaires. So if you look them up online, just type in Patient Health Questionnaires. You can even type in PHQ because they're known as the PHQ, whatever number of items they have. So these are very easy to use. They're in more American English, but it's more straightforward in terms of translation. So that is actually one thing. They're not in colloquial language, but they're in fairly simple to understand language. Many health organizations actually recommend these scales. And I've heard people say, oh, these haven't been validated for perinatal women. It's not true. So there's a lot of organizations that have actually recommended these, like, the NICE, which is the the National Institute of Clinical Excellence in the UK, which has actually validated their scales. You have a lot of U.S. organizations like the U.S. Preventative Task Force on Depression recommended this even for perinatal women. So yeah, I've run into people said that. And I ran into people say that when we did a journal article review. And they're like, why did you use this? It hasn't been validated. It's been validated right from the start. When they did the initial validation of the scale, they had two samples. They had a primary care and they had a perinatal. So right from the start, right from the beginning, it was validated. So don't believe that. So the PHQ-9 is the master inventory. And again, multiple item. There are no reverse score items in this. So that makes it kind of nice. So basically, the higher the numbers, the more severe the symptoms. What some people consider to be a major limitation of the scale, and I think it's one you should be aware of, is it doesn't ask at all about suicidal ideation. That's kind of important. There are some other scales that actually can help with that. And so, you might want to look into those if you don't use the scale. So for a lot of years, I used the PHQ-2, which is basically concentrating on two symptoms. Now, remember, screening scale. You're just trying to get an idea on kind of where they are. And then if somebody screens positive on this 2-item scale, it's probably appropriate then to use the next one, which would probably be the full 9-item. So there's scales that are very easy to do. The two things that the PHQ focuses on are anhedonia. So you're asked if you have little interest or pleasure in doing things, and if you are feeling down, depressed, or hopeless. So depressed mood. Okay, so those are kind of the two chief concerning symptoms about depression. So it gets right to the heart of it. And, again, I've kind of liked the brevity of this. Nobody's going to make a diagnosis on that, but it is definitely a red flag. So you definitely want to kind of ask about this. But more recently, there's another version that's come on, which I kind of like even better. And that is the PHQ-4. Because remember with the Edinburgh 3, one of the reasons why it was more effective than the long version was because it actually had because it actually was asking about anxiety. Okay, and so the anxiety questions for some reason seem to be more predictive of anxiety/depression, which many depressions are. The PHQ-4 to me has an advantage because it takes the two depression scales from the PHQ-2 and adds two scales from the generalized anxiety scale. So generalized anxiety disorder 2. So it takes those two questions. So it's got depression questions and specific anxiety questions. So again, I think those are actually kind of nice. And it's been used widely with a lot of perinatal sample. Pretty recently was the Listening to Mothers California study, Another study where they looked at 6,874 women, that's Basel et al. 2024. These women were for 64 countries. And they actually found that the results from the PHQ-4 yielded scores that were consistent with PTSD and worry, and also that they found that 31% of the mothers that they tested exceeded the threshold for depression and anxiety. So you can tell it's pretty sensitive. So again, it's not a full scale, but it gives you an idea of kind of what else is out there. Okay, so in addition to talking about no pleasure in doing things and having depressed mood, it actually asks you if you've been feeling nervous, anxious, or on edge. And so you notice it's kind of gotten rid of the for no good reason language. And then also not being able to control or stop worrying. So it's kind of like that, again, gives us an idea of this really heavy level of anxiety. Often mothers who score high on these, you also find that these are the mothers that often start supplementing. Anxiety is highly related to supplementing and not exclusively breastfeeding. Because if you're worried, you sit there and you think, oh my gosh, is he getting enough? I'm not sure he's got enough. Maybe I better do a top. And they don't understand that sometimes even when babies are full and perfectly satisfied, if you stick a bottle in their mouth, they're going to drink it. Doesn't necessarily mean they're hungry. If they're not showing any other signs of hunger, they're not crying, if they're growing well, if they're going into milk drunk punch society, they just kind of like go fall over and they talk about milk drunk and they've got milk dripping down their mouth. They're not hungry. But just stick a bottle in their mouth, they're going to drink. And if you're feeling very anxious, you can see how this can happen. So it is kind of important, especially if the goal is, going toward helping mothers exclusively breastfeed. Dealing with anxiety is really important. Just not dismissing it, but saying, can you tell me why you're anxious? What are you anxious about? And then say, okay, so I'm going to show you how to know that your baby is actually doing fine. So kind of give them a little more control. But this doesn't necessarily mean jump in with a bunch of medications. A lot of mothers really kind of object to that, but there are a lot of amazing interventions that you can do that actually don't require any medications at all. And anxiety is one of those ones. So obviously somebody with severe anxiety that's just keeping them up, they can't sleep, that's a different thing. But, oftentimes we can kind of, if we just talk to them, because unfortunately this kind of stuff tends to, you start getting nervous about something, and especially you add isolation into that, and they start chewing on it, and they start thinking, oh my gosh, this is so bad, this is so serious, and it's worse. So one way that providers can really be helpful is just to talk to them about it. Don't dismiss it, but say, okay, I understand that you are worried about this. Let me show you what to look for. If their partner's there, show them too, and say, this is how we can know if everything's going okay. If they're at home and they're just crawling the walls, it's probably a good time to go out and take a walk. Put that baby in a baby sling or get the stroller, go out and take a walk, go be with other people. So these can be clues of kind of what can we do to help you through this time. Okay, but also with an eye toward, should we talk about taking some next steps? So I want to just briefly mention just a couple of other scales, just because I think it's important to know that there's a few other tools out there. One is developed by Cheryl Beck. It's called the Postpartum Depression Screening Scale. It's much more in-depth than any of the other stuff. And unlike some of the standard diagnostic tools, it is actually geared specifically for new mothers. So that, I think, is an advantage. A disadvantage, that many people identify is this, you do have to pay for this one. Another one that people have liked is the City Birth Trauma Scale. So let's say you're dealing with an issue. Your mom, that you're working with has had a traumatic birth. This is a scale that you can measure that. Okay, I will warn you a couple of things. And I just know this as a trauma researcher, and I also know this as the editor who's published many of the translations of this. This scale tends to have identify lower rates of trauma than other scales. Okay, so I like it because it is specific for birth trauma, but there's a couple of things. First of all, they use the DSM-4 criteria for the traumatic event. Okay, so that's in trauma world what we call the criterion A event. So what that means is that does the event rise to the level of severity that we would call it trauma? Okay, so right now under the current guidelines, that it is the severity of an event that can either be experienced or witnessed is death or threatened death, actual or threatened physical harm, actual or threatened sexual violation. Okay, now in the older version, the DSM-4 version, they actually also added, and the person experienced this with fear, helplessness, and horror. Now, when they did the DSM-5 version, they actually dropped out the fear, helplessness, and horror because they felt like, although many people can experience those things, fear, helplessness, and horror, not everybody does. And so they put those into symptoms, but not as the criterion A. Because, unless you meet that criterion, you really can't be talking about a diagnosis of PTSD. So because this scale uses the fear, helplessness, and horror, it tends to actually have lower rates. If you were going to use the scale, I would also recommend that you use another one, which is the patient checklist or the PTS checklist 5. Okay, so it's called the PCL 5. That's available online. Again, just Google that. That's a general trauma. So it's not specific to birth. It's not significant to postpartum. But if that one is higher, then you kind of have an idea that the City Birth Scale probably measured the lower percentage of women with depression or PTSD, excuse me. But at least can give you the symptoms. Now, the other thing with the City Birth Trauma thing, and again, this you might think, this is just methodology, but I do think it's kind of crucial. Is remember we talked about death or threatened death, actual or threatened physical harm, actual or threatened sexual violation. They did not ask any questions about sexual violation. And if you know this literature, you know that that is often an issue because you are dealing with parts of the body that are private parts and can be violated. And so for many women, that is a critical part. And that, unfortunately, is left out of the scale. And I don't entirely understand the rationale for that. If it had been me, I would have written it. But honestly, if it had been me, I could have written a scale. So didn't do it, and that's it. And finally, there's another scale. If you want to look at sleep, there's one called the Pittsburgh Sleep Quality Index. Again, it's just a standard sleep measure. But take the findings of it with a little bit of grain of salt because it's not geared for new mothers. So it says if you have a lot of nighttime wakings, that they consider that pathological. Well, it's kind of hard for the course with new moms, but it can give you an idea of the level of fatigue that she's feeling. Okay, and also too, another one, if you're considering medication, the mood disorder questionnaire, this one might be important to do because it's a measure for bipolar. Now, the reason I say that is oftentimes what happens is people can experience bipolar, and this is a lot of times the underlying condition for much postpartum psychosis. And what happens is people test positive for depressive symptoms, then they're given antidepressants, particularly SSRI antidepressants. That can trigger, in certain vulnerable people, a manic episode. Okay, so if you are considering medication, before you do that, you might consider doing this just to see if there is any risk for some underlying bipolar, because unfortunately that can actually lead to tragedy. And that can actually lead to postpartum psychosis. So we want to be a little bit careful there, especially if there's any family history of that, because that does tend to run in families. It's kind of a rare phenomenon, but it's a really serious one. So with that, also too, I talk about a couple of, risk questions that you can ask about suicide risk, sometimes the previous history, but also, and this is something that's probably good to ask, but the Edinburgh does ask this, want to find out if they're thinking about suicide. They might not volunteer that to you because it's shameful. They'll think, but also if they have any history of substance use, if they have a personality disorder or a family history of suicide. But also too, the really long periods of insomnia can be a real red flag. And that can be actually related to that sort of bipolar, which can be a trigger. I will tell you that just when you are talking to moms, and if they tell you they haven't slept in 2 or 3 days, that's a call your doctor, and that's an emergency room visit. Because every single person that I've interviewed over the years, I've interviewed a lot of women for my books, and every single person had an episode of psychosis. That was the symptom that preceded it. So that kind of intense sleeplessness, that's not just normal newborn stuff. That's serious. And so it could be that it's just there's something that's pretty easy to solve, but man, get that checked because that could be quite serious. And see, as they've kind of listed that as a thing that is a risk factor. Also, too, if they have the morbid post-traumatic stress disorder is another one of the risk factors. And so again, these are just some things to kind of screen for. Screening is really important, but it's the first step. And then we kind of can sit down and say, okay, what are the next steps? What do you need to think about doing? And I will see if we can cover that in subsequent podcasts. I think that would be helpful if you just know what are some options here. Because again, people say, oh, we don't have the money. We don't have to be the grant money. We don't have the time. I'm telling you, I have seen, because I have traveled in every single state of this country. I've traveled all over Canada. I've traveled all over Europe, Australia, New Zealand, and even China. And I can tell you that people can do a lot at the community level. I've always been impressed by some of the things that I've seen. And it starts with people deciding, I think I want to do something about new mothers in my community. And you can pull people together because chances are there are other people in your community who feel the same way. So again, you don't necessarily need millions of dollars. I mean, obviously, millions of dollars are nice. I certainly wouldn't say no, but there's places to start. But the first step is doing those screening, but then I want you to think that this is step one. And then after that, what are you going to do? Okay. Again, this is part of thinking about a plan. And we can think about that kind of realistically. What's doable, what's not, and where can I refer mothers? Okay, I'm going to wrap this up for today. I want to say thank you very much for listening. I will actually be recording some more stuff on some of the treatments and some of the things, especially that can be done at community level, because I think that's really important. If you want more detailed information, I would encourage you to get a copy of this book. This is Depression in New Mothers, Volume 2. It's from Rutledge. It's 2024. This is the one that talks about screening and goes into a lot of detail. So if you need justification, like say, for example, writing a grant application or something, it's all there. Okay. And if it also goes through step by step what all the various treatment, everything from community support to, nutritional things that help, all the way up to medications. Okay. There's a full range of stuff that's available. It's really, I have to say, this is kind of a golden age in terms of opportunities and things that you can do for depression. So I want to say thank you very much for listening. And I am going to stop now, and I will see you again soon.